Swayam Prabha. Digital India. Educated India.
Welcome friends to our NPTEL MOOC module on health economics. As you know that this course is unique in the sense that healthcare is very essential. It requires strong policy making. It requires attention in every field, especially when we are counting its financing aspects. And as we have seen that the healthcare spending is an important indicator of decisions in household, because of the fact that their spending percentage is very high, or the private spending is very high. Whether it is the market who is going to deal with the provisioning, or it is the government. So whether market really fails in this context or not, etc. There are so many directions comes. But at this moment, we are not addressing all sort of things. We are only sticking to healthcare financing, and this is the one where we are actually deriving from our previous unit, and that one that was on equity in health. Okay, and where we emphasize about equity in health distribution and equity in healthcare access as well. In this lecture, we will be discussing on healthcare financing, laws of health resource allocation, and healthcare financing in India in particular, with the reference to the latest important government document, that is health accounts, also called National Health Accounts, NHA 2019-20, and we will be also discussing on capital and current health expenditure. So, as a background to this unit on unit number 5 on financing and insurance in healthcare, our title is accordingly defined. Here is healthcare financing. It's the title we are carrying for this unit. So, what do you mean by healthcare financing? It's basically a system that a society uses to pay for healthcare services. Financing healthcare has evolved from personal payment at the time of service delivery to financing through health insurance prepayment by the employer or employee at the workplace. We have already discussed in other units, even in healthcare systems unit as well. In the health financing cases, this involves not only the methods of raising money for healthcare, but also allocation and use of those funds. In the subsequent slides of this lecture, we will explore the generation, allocation and use of these funds. We will also highlight how healthcare financing is made in India as well. So, emphasis will be on Indian context. Starting with the healthcare financing, we will be certainly emphasizing on household, where the payments are actually made from their own pocket. That is basically called out of pocket payments, and hence they receive treatment. Okay. In ordinary market, there are two stakeholders, consumers and producers. Consumers are the users who hand over money in exchange for the service, and whereas the sellers or the producers who receive the money required for their cost of providing those goods and services, or healthcare providers. So, and sometimes it involves the role of third party. It is not just the household and the healthcare providers, there might be a third party. Third party is called private insurance providers, government insurance provider, or social insurance funds. And how it works, it starts with paying for healthcare from the household side, in terms of user charges, private insurance premiums, social health insurance and taxation to the third party, and it is the responsibility of the third party to provide healthcare to the households through the healthcare providers. Hence, there are reimbursements. Okay. The involvement of a third party, they are actually the financial intermediaries who serves the dual function of generating revenue and reimbursing service providers. There are a principle which is followed in theory. We are referring to Evans 1997 paper, that is called revenue expenditure income identity principle, which explains the flow of money in these three heads, starting with revenue, expenditure to income. The sum of the revenue generated from different sources represents the total budget for possible expenditure. This expenditure will always end up as income to those provide the services. Now, revenue, how revenue is generated? It is through patients payments, that is called PP, private insurance payment PI, taxation on health that is TH, and voluntary donation called VD. So, expenditure is equal to the unit of cost times the quantities of the healthcare commodity, whereas income is the hours of labor times the wage rate paid to the laborer. Hence, these three are presented here. This is the one, this is the second one, that is expenditure, and this is the third one called income. So, and this is highlighted here to just clarify that this identity are required in the financing structure. Any change in one variable lead to the change in at least one another parameter. It can be either offset or balance by a change in other parameters on the same side of the identity. So, that the change maybe change is mentioned as maybe equalized with its mode value. The change in TH might be negative, but equalized with the change in the PP, that is called patients payments, or the change will lead to the same size total change on each of the other two sides. That is basically when the TH falls, the quantity of these commodities will fall, and the hours of labor requirement will also reduce. Hence, there will be some adjustment. Therefore, we said it is called revenue expenditure income identity in the financing structure for healthcare. Once again, we are just clarifying, starting with out of all citizens, there are certain percentage of patients who require help from the health providers, okay, and there are voluntary donations accordingly, and or the patient payments. Hence, they receive commodities, as we have already mentioned, as sum of CIs times their quantities, and they also receive income in terms of labor and their per unit wage rate. So, these three, first we say their expenditure, then their these three identity revenues, expenditures and income we have explained. Now, again through the third party, it is channelized through their taxation on health, then private insurance, and there are reimbursement to the healthcare providers. This is explained for your clarity, and we will be further clarifying each of the directions. So, health resource generation, as I already mentioned, total revenue is through patient payments, private insurance, taxation on health plus voluntary donations. The distinguishing characteristics of four sources of revenues deal with whether payments are made ex ante, like prior payments are required before sickness, such as premium payments etc., through the third party, or ex post, even that is at the time of service or just after the sickness from the patients. So, the payments are either ex ante and ex post, whether paid fully on an individual basis depending on the individual's healthcare use, or with any element of cross subsidization. Either the individual is fully paid or there are some redistributional channel through cross subsidization. We will discuss all these things here. Here are the characteristics of these channels and the relationship of financing. So, as I already mentioned, through ex ante, ex post, or no cross subsidization or cross subsidization, we will clarify one by one. In case of cross subsidization, the rich or the healthy subsidize for the poor, okay, or the for the sick. Hence, this has a linkage with redistribution of income. Why do people pay ex ante rather than ex post? To avoid, of course, the answer is to avoid risk. I will clarify all sort of things. The distinction between ex ante and ex post deals with the extent of people's preferences for health insurance, and risk aversion is the key, where ex ante payments are made as premiums, while distinction on vertical axis deals with the extent of people's willingness to cross subsidize, okay, and their fellow citizens use of healthcare through redistribution, whereas the horizontal is actually emphasizing on the ex ante and ex post principles of financing. Now, we are addressing health resource allocation. Due to limited availability of resources, fund allocation has huge competition in any health system. Decision of allocation affects what services are provided and which services to be given priorities, etc., are important. Economic consequences of decision made in resource allocation are major determinants of healthcare economics. Balanced resource allocation for all the subsectors of health system is required to ensure regional and socio-economic equity. Now, we are presenting some of the principles and the laws of health resource allocation, starting with Sutton's law. This is taken from, you can just have a recheck. We have cited the source, Economics of Health, published New Public Health in 2014, and the page number is also cited. First, Sutton's law, this discusses about the priorities, how priorities can address the resource allocation efficiently. Based on a statement by notorious American bank robber is Willie Sutton, when the reporter Mitch Onstad asked Sutton why he stole from bank directly. Sutton answered that because they did it because that is where the money is largely confined, and one's first choice would be to choose the most obvious route of extracting money. And similarly, in healthcare, wherever the need is the most, emphasis should have been given. Taught to medical student as a metaphor for emphasizing most likely diagnosis, rather than wasting time and money investing every conceivable possibilities. That is all about called Sutton's law. Second one is Capon's law. This is based on statement by Capon, a well known again gangster, while dividing the area of Chicago among the colleagues. Like they usually gangster divide their areas, this is their zone, this is their zone, there should not be any conflicts of service. Similarly, healthcare also it is applied. In health context, planning should be actually made accordingly, not necessarily it is the single planning model that will address all the providers and all the choice functions. Hence, planning may reflect the provider's interest instead of public interest so far as Kappan's law is concerned, which is actually creating problem. So, so Kappan's law mentioned that the area wise division of allocation of the resources is very important. Another is called Romer's law, that's on hospital beds once built and insured will be filled. It is to some extent explained through supply side creates its own demand kind. As the supply of hospital beds increases, the use of hospital services also increases. Excess hospital beds leads to an overutilization of hospital services when the observed demand outpaces the population's actual need for services. Incentive to control both hospital bed supply and utilizations are important in health planning in industrialized countries. Next one is called Bonker's law, like more surgeons and more surgery etc. A greater supply of surgeons generates more surgery. Managed care and gatekeepers functions limit referral to specialists. Professionals, organizations and governments limit training positions and licensing for such specialized services are required. Now we are taking count of the national health accounts as the latest evidences to give you the understanding related to health financing. Health accounts, what is this? This actually accounts for health expenditure and flow of funds in the country's health system over a financial year of a country. It focuses on what are the sources of health expenditure, healthcare expenditure and who manages these, who provides healthcare services and which services are indeed utilized. Health expenditure estimates are prepared according to global standard framework, that is basically called System of Health Accounts SHA in 2011 or 2011 period. Our health accounts are actually maintained as per the SHA. So, hence India's health record are actually comparable across the globe. System of health accounts, that is basically an international accounting framework for systematically tracking health spending. SHA 2011 establishes an integrated and comprehensive methodology for tracking health expenditure through a set of uniform accounts comparable across countries. It has a coverage on final consumption. It tracks resource flows through the health system from their sources, patterns of provision including providers and factors of provision, through to its use, healthcare function, disease program etc. So, there are regarding total health expenditure, there are different disaggregated units such as current and capital expenditure. We will be emphasizing one by one. Coming to current health expenditure in short called CHE is presented as it includes revenue of healthcare financing schemes, then healthcare financing schemes, then healthcare providers, then healthcare functions. Like when we include revenue of healthcare financing schemes, this entitles that provide this provides resource to spend for health goods and services in the health system, whereas healthcare financing schemes entities are receiving and managing funds from financing sources to pay for or to purchase health goods and services. And regarding healthcare providers, these entities receiving finances to provide or to produce health goods and services. Healthcare functions describe the use of funds across various healthcare services. On the other hand, capital expenditures covers the expenditure for capital generation such as new infrastructure, training of doctors etc. But current expenditure really matters matters much to deal with the everyday challenges. Now we are further clarifying with the facts and figures regarding total health expenditure. We have mentioned that it is of two parts, current and capital health expenditure. So, coming to capital health expenditure, this is indeed called as capital health expenditure because it deals with level of capital investment on health Capital health investment include health infrastructure such as buildings, machineries, technology, IT, stocks of vaccines for emergency and outbreaks. Whereas in case of current health expenditure, this has estimates of current health expenditure such as healthcare goods and services consumed during each year. This indicator does not include capital health expenditure such as building machinery, etc. So, here are the key health financing indicators which needs which need emphasization or we will emphasize like total health expenditure which I already mentioned, and but it should not be just its absolute amount that is important. It has to be taken as a percent of GDP and in per capita terms. Current health expenditure as a percent of the total health expenditure, government health expenditure as a percent of total health expenditure, out of pocket expenditure OOPE as a percent of total health expenditure, social security expenditure on health as percentage of total health expenditure, private health insurance expenditure as a percentage of THE, the external or the donor funding for the health as a percent of THE, and government health expenditure or the GHE as a percent of general government expenditure GGE, household health expenditure as a percent of total health expenditure, union or state government allocation of health or health expenditure as a percent of GHE, that is government health expenditure. Recently Ayush ministry has been emphasized and its allocation as a percent of total health expenditure, pharmaceutical expenditure and out of the CHE or the current health expenditure. So, as mentioned, these are the important indicator of the national health accounts of 2019-20 of India, and I re-emphasize again that these all are really interesting if you are extending your work in your research in healthcare, especially those who are working on efficiency analysis, or productivity analysis. These indicators are the must. We have also discussed in our chapter in unit number 10. You can also recheck. These are our some of the inputs in health efficiency, and these are going to be useful for writing articles, research articles, and even in consultancy services and their analysis. So, now health financing in India and its records from the National Health Accounts 2019 figure are explained in our slides. And here you just read between the line and its figures. You can see very clearly that the current health expenditure carrying more than 90% of the share, okay, as of the capital health expenditure, and out of the total health expenditure share. And these are the different years where as per the NHA record, National Health Accounts record, starting from 2013 till 2019-20 figures are here. There are different key indicators which you have already emphasized as like total THE as percent of GDP, THE per capita at current prices, etc. There are which one has been declining, which is increasing, which is indeed current health expenditure is actually declining, government health expenditure is rising, out of pocket expenditure is also declining, which is indeed good. As per the latest figure of NHA, it is only 47.1%, and this is OP as a percent of total health expenditure. Total health expenditure as percent of GDP declined, share of current health expenditure decline, means more capital expenditure is there, and OP decline, but still it is a sizable percentage. Who contributes to current health expenditures in India? Like you can just have a check. The most important contributor to the current the running expenditure for healthcare is through the households. households carry around 60% of the total share of the current health expenditure. It is the exact figure is 59.25%, and out of 59.25% paid by household, 52% is out of pocket expenditure. Okay, that is another interesting aspect, which is still very high and should be reduced. Now, what services are consumed from current health expenditure in India? Now, you can just have a see. Inpatient curative care, outpatient curative care, and day curative care. That's these three indicators covering more than 50% of the services from the current health expenditure. Now, coming to the again current health expenditure, who provides healthcare services from current health expenditure? You can just see the share is here mentioned, and there are percentages. You can just have a check. Private hospitals, they are providing a percentage is higher, followed by the pharmacies and then government hospitals and so on. Who contributes? Now we are actually discussing about capital health expenditure. Who contributes to capital health expenditure the most? You can just have a check. It is the union, it is the state government. As we know that health is in concurrently, state government share is highest, followed by the union government. Gross fixed capital formation in the health system is measured by the total value of the fixed assets that health providers have acquired during the accounting period and that are used repeatedly for more than 1 year in the production of health services. So, you can also use gross fixed capital formation as an indicator in your analysis for your research paper. Impoverishing effect of healthcare payments in developing countries like India and underdeveloped countries, where most of the population live below or just above the poverty line. They face the risk of being pushed into the trap of poverty as of high health care spending. This phenomenon is also known as impoverishment effect. Okay. Now, you can just have a check some of the figures we have taken from one article of EPW, Economic and Political Weekly, published in 2010. We are just citing these authors who have calculated the impoverishment effect. You can see the impoverishment effect is by inpatient care and the outpatient care. It's different in Kerala, especially outpatient care is considered to be high. And why is it so? It is due to the fact that the healthcare provisioning is also much higher in Kerala, whereas it is quite low in some of the other states like even in state of Odisha, even in Madhya Pradesh. All right. So, it depends on how people are actually utilizing from their own pocket, and hence they are at the prey of paying higher amount, and their resources are allocated largely on healthcare, which is to be addressed by policy. You can just have a check. We have highlighted on the national average is here, and there are states which have exceeded the national average. Here we need to cite once again. Kerala shows highest effect, that which I just said may be due to low levels of household consumption combined with higher education and propensity to use healthcare. Madhya Pradesh shows low rate of health related impoverishment, that is maybe due to high level of the base of poverty and low education and lower access of health. Outpatient services account for larger share of financial burden than inpatient. So, these are some of the directions for all of you to work for your own research, will be useful. Hence, it has connection with poverty. There is an association between out of pocket health expenditure and poverty. OP will raise financial hardship. Health expenses versus other necessities are the challenges posed with the family, and there will be catastrophic effect. you might see that 40% of the expenditure might exceed their out of the total non-health consumption goods. There are different catastrophic expenditure articles you can refer. Okay. And in India, as per the NHA figures, NHA 2019 figure, OP as a percentage of total health expenditure is 47.1%, whereas out of the current health expenditure is of 52%, which is still much higher than many countries in the world. In another article of Sirag and Noor studied the data study from the data of 145 countries between the year 2000 to 2017 found that if OP exceeds the threshold of 29%, this leads to increased poverty in the households. This kind of work relevant for further research. Now, we have already discussed financing and funding Indian healthcare even earlier chapters. In our other chapters, we discuss about health systems, and we cited about Bismarck and Beveridge model. India is a microcosm to all the healthcare system in the world as per the PwC report. This is even from the PwC report, and where you can see number of indicators related to payer, financing, provider, government's role, price controls, and even there are different examples wise which country follow which kind of model. If you are facing some difficulties in understanding the clarification of each of these, you need to follow our health system chapter. Okay. We discuss this in chapter number 7 or unit number 7, that is on economics of health systems. Healthcare models will be covered as I already said, since this is our unit on 5. So, we are going to cover this in the economics of health system in unit number 7. Okay, so, it is largely covered. Rest, if you have any difficulties, do reach us, and our team will be very happy to address each of the directions. The most important readings for you is here the NHA, which I have already said, for all facts and figures for Indian context. NHA, National Health System, Health Accountability or accounts, National Health Accounts is very important. So, this will give you all the estimates related to the Indian health systems and its estimates. Ulsen Abel paper book published by Oxford University Press on principles in health economics and policy is also important. So, these are all. I think in the next lecture we will continue the health financing structure, and we will also explore the concept of uncertainty and health insurance in detail. Hence, it is going to be very useful. I suggest you to get the best out of it. Thank you.